Welcome. I'm Neel Shah, I'm the Executive Director of Costs of Care, and welcome to Teaching Value, a series that's jointly run by Costs of Care and the ABIM Foundation, where every month we talk to an innovator who's either on the ground or at the national level that's working on new strategies to improve care for our patients, care that leads to better care at lower cost. You can find these, both we have a webcast and a podcast. You can find them on YouTube by typing in Teaching Value or by typing in Teaching Value to iTunes. And in addition to the monthly web and podcast series, we have a discussion group that has hundreds of trainees and faculty members around the country that you can access through the costsofcare.org website, along with a lot of the tools that have been developed along the way. In the past few months, we've been lucky enough to talk with leaders at the Institute for Healthcare Improvement, Consumer Reports, Johns Hopkins Bayview, and today I'm very, very excited to welcome Dr. Wade Iams, who just finished his chief year as the chief resident at Vanderbilt University in internal medicine, and is now moving on to the University of Chicago as a hematology oncology fellow. And at Vanderbilt University, he led a really interesting initiative, an important initiative, where they used house staff as a vehicle to implement many of the important Choosing Wisely recommendations. So Wade, I'll turn over to you. Thank you so much for joining us today.
Dr. Shah, minor correction, I'll be at Northwestern for a fellowship, but
apologies for that.
And I'm going to go ahead and get started. I appreciate the opportunity to talk about our work at Vanderbilt, which does continue despite my transition away. There are other leaders in chief residency and residency who have taken my place at Vanderbilt. And what I'm going to talk about today is a pilot initiative that we have implemented at Vanderbilt, which is the reduction of unnecessary daily laboratory testing on our medicine and surgical services. Since the initial introduction of this work in 2013, we've expanded to reduction of unnecessary daily chest x-rays and telemetry overutilization. But for the sake of implementation strategies, details, I'm going to be referring primarily to our daily labs work. This work at Vanderbilt began in December of 2013, and there was not an existing high-value care curriculum that we were using at the time. Since 2013, there have been many different strategies employed by other academic medical centers, and I'll talk about that at the end of my presentation. I have a summary slide just from a national landscape perspective. But in December of 2013, our graduate medical education committee leaders encouraged trainees to get involved in implementation of high-value care initiatives. This was a call at the American Association of Medical Colleges annual meeting in 2013 that trainees should be involved in this, both leadership training and high-value care education. So that was the origin of our Choosing Wisely Steering Committee at Vanderbilt that has been led by trainees since that time in December of 2013. Of course, we couldn't accomplish anything without the faculty support we've had. So we've had our designated institutional official involved and program director leadership, significant leadership from our Department of Hospital Medicine at Vanderbilt, but integration of trainees with selection of priorities and project implementation has been a key aspect of our work all along. So that's the background of our work at Vanderbilt. Our model for implementation follows John Cotter's 8 steps of organizational change. So I'll talk through these steps for the primary mechanism of imparting implementation strategies, and happy to answer questions along the way at each step, anticipated barriers that I'm not touching on for the sake of time, and get into any issues that may be variable at different medical centers. For establishing a sense of urgency and forming a powerful guiding coalition for our work at Vanderbilt, we really utilized the Choosing Wisely campaign as a sense of urgency. And in medical education today, all are inundated with slides showing our healthcare spending as a percent of GDP compared to other industrialized nations, and it being excessive, especially compared to our at best comparable healthcare outcomes in our country. So that really I phrase it as a high-level sense of urgency that we all internalize during medical education. And the second tier of sense of urgency is specific recommendations, such as has been made by the ABIM Foundation's Choosing Wisely project. So this is all excellent, but I do think that there has to be a third tier of sense of urgency on an individual medical center level, because each medical center is going to have different issues, so to speak, or different choosing wisely priorities that are being not followed. So at Vanderbilt University Medical Center, the way that we added that additional sense of urgency was by having all steering committee members, trainees, and faculty alike create top 10 lists of choosing wisely recommendations that they thought Vanderbilt should target first. So this adds a level of personalization to the Choosing Wisely campaign, and it also whittles down goals to a reasonable pilot project. So I think those are important aspects to factor in when going about high-value care implementation.
Wait, out of curiosity, I think in the generation of the Choosing Wisely lists at the professional society level, often the challenge wasn't coming up with the 5 things, it was deciding which things should go on the list, and that sort of back and forth. And as you sort of talk about your implementation strategy, one of the early questions I have is, did you find that it was the case that actually coming up with 10 things was relatively easy, whether it was faculty or trainees? And then, regardless, once those lists were generated, what was the process of coming to consensus around where you'd focus your effort?
In the interest of time, that is time on the part of steering committee members, I think that was the difficulty in identifying the most important priorities. And an area of focus is important to lay out from the beginning. So having an area of focus as our general medicine inpatient services inherently narrowed down the list, so it made it easier for our steering committee members to do that. And from the trainees' perspective, I think it was not too difficult to identify general medicine priorities from these Choosing Wisely lists. They were things that we were doing reflexively. Maybe we thought that our attending physicians thought that they wanted these, when in fact with implementation we found that in many cases they didn't. So it was not as difficult as it would seem, but that was because we had a narrow focus already. We had our general medicine services as our known pilot group.
What was sort of the strategy? Like, were you sort of thinking, if we're going to go after, say, unnecessary labs, is that low-hanging fruit? Or was it sort of, you're going for impact? Like, when you're sort of thinking about the first incremental step, how do you think about that trade-off? Are you biggest money? Are you going for the most harm? Or how do you sort of think about that?
Great question. I think it has to be low-hanging fruit. That's my perspective because of the success we had with our pilot initiative and the institutional support that initial success can garner. So there are other ways to approach high-value care implementation, as you've alluded to, that we've gotten into since 2013. We have at Vanderbilt a diagnostic lab advisory committee, and the Choosing Wisely steering committee within that broader umbrella is a group that targets non-expensive tests that are frequently overdone. There is a component, an arm of that group that targets high impact, high cost reference and send out tests that really shouldn't be being done in the inpatient setting. So
pretty broad institutional support. Was that something that you had to sort of generate and advocate for? Was that something that you sort of already had a lot of willing champions on the ground? You said that part of the genesis was a AAMC meeting that helped kick this off, but would you say that it was a combination of faculty leadership and house staff leadership? Was really house staff initiated?
It was faculty leadership initially in prompting the work and providing insight into a pilot project that, if successful, would garner significant support. And the initial implementation was primarily house staff leadership. So it was a joint effort, but institutional support was garnered after approximately 3 months of success and a good degree of lifting on the part of house staff for initially manual data collection, but with success and institutional support that I think to some degree was contingent on the pilot project success, but once the pilot project was successful, we garnered institutional support for automation of data collection from our informatics department. So it was a back and forth, but initially faculty, and then putting it in the hands of trainees, seeing where they would go. And if the pilot project was not successful, I don't know what our trajectory would have been, but those are the reasons that I think that starting with narrow, low-hanging fruit is very important to gaining momentum in this work.
Right. It sort of helps the institution also continue their investment, it sounds like, in addition to getting the investment of the folks on the front line.
I think that when high-value care projects are implemented, it's important to be motivational to frontline clinicians and reiterate that being judicious with healthcare resources is really an ethical component of medical practice, and this is what physicians need to be fighting for, and it's very important work because many times I think that high-value care and quality improvement projects that are purely top-down can feel punitive and can feel like they oppose the goals of the frontline clinicians. So really phrasing this and getting people to understand that this is what's best for the patient and emphasizing the unseen harms of a lot of unnecessary testing is a critical theme. We emphasize that. And also emphasizing, this is a clip from Goodwill Hunting, that the culture of medical overuse and approaching improvement on it has existed for a long period of time. And in trying to change people's behavior, we're not essentially saying it's all your fault. We're saying that there is an issue that we need to address, and not approaching it in punitive measures, and not approaching it as singling out individual frontline clinicians, I think is an important precept that we've always emphasized. Also, a component that I'm proud of from our work at Vanderbilt is that we never defined what was a necessary or unnecessary test. We laid it in the hands of frontline clinicians and said, there is a problem of overuse in this realm. We think that our lab ordering rates, our telemetry utilization rates, and our chest x-ray utilization rates have room to safely improve. But we're not going to come back to an individual and say, this one test was unnecessary. And I think that's very important in empowering clinicians to act on this data.
I agree that that's an important point. Let's delve into that for a second, because I think it's important before we even get into a conversation about sustainability and potential challenges to really understand the meat of the intervention. And I think in 2016 we're living in a world where for a lot of quality improvement work, audit and feedback is very important. For example, C-section rates are too high, but I don't even know my C-section rate until somebody tells me what it is as an obstetrician. So, this seems to be a core component, and there's often this idea that you can't improve what you don't measure. But on the other hand, you want to preserve necessary discretion and not be punitive and sort of crowd out people's motivation. So help us understand how it was that you primed the clinicians to change their behavior if at the end of the day you're not, getting all up in their grill about what they did and what they didn't do.
Emphasizing the hidden harms is a key component to establishing buy-in when you're talking about, to some degree, depersonalized rates of overutilization. So we emphasized hospital-acquired anemia, the disturbance of awakening patients at 4 a.m. to do lab testing. One of our initial figures that I don't have in the slide set was pulling data from the institution about when are daily lab tests being drawn, and over 3/4 were drawn between midnight and 8 a.m. So we're interrupting patients' rest time when they're acutely ill. So emphasizing those unseen harms, I think, is key to starting the conversation about buy-in.
And how was that information delivered? How were people primed?
We had a didactic session at whatever was the most well-attended didactic for the department we were approaching. So in internal medicine, it was a weekly Tuesday noon conference. In surgery, it was a weekly Thursday morning conference. And for the hospitalists, they have a monthly gathering. So whatever was the most well-attended by the department, we had a 15-minute segment where we showed these images and emphasized these are the themes that we're approaching this audit and data feedback with. And we're not going to come to you and say this one test that you ordered was unnecessary, but we do have a problem.
That makes sense. And so you sort of you prime people up front by showing them these images, and then even if you don't scrutinize individual ordering, did you report back progress along the way?
Yes, so it's important, I think, at the time of that initial didactic session to be ready, to be prepared to initiate the data feedback immediately. So we didn't do the didactic session until we had individuals identified who were going to pull the data and send the data to folks who were on service at the time. So I think immediately after that, you have to send the data and say, hey, your daily CBC and BMP ordering rates are at 95% of patients getting this test. So do you really think that 95% of the patients need this test done? And in most cases, it was no. That was a component of being low-hanging fruit. But I think being ready to follow up that didactic session immediately is a key component as well for sustainability.
That makes sense. And as you were sort of showing people their progress or their lack thereof or the room for improvement, did you have I mean, I guess, you know, in this setting, if 95% of people are getting something and a lot of folks don't need it, that's probably all you need. But did you have any benchmarks? Did you have a way of, I remember a competition or a challenge was part of this. Do you have a way of sort of comparing people to others and sort of use that as a motivation?
Yes, absolutely. Great question. So there are four general medicine teaching services that have analogous patients. So we compared those four services to each other. There was one step of de-identification in that we sent the data that we had acquired to all four teams as this is team one's rate, team two's rate. So it wasn't this is John Smith's rate compared to anyone else's rate. You could find that out if you were so inclined in looking at call schedules, but we included a form of de-identification but peer comparison. So everyone knew what their rate was compared to their peers, which I think is a critical component. And as far as benchmarks, we were very fortunate with our pilot project. We really chose something that we had a very high likelihood of success because at Vanderbilt in the early aughts, there was a publication in Annals of Internal Medicine where the ability to order recurring daily labs was altered in the computerized order entry system. So at the time of that study, there was a 50% absolute reduction in CBC and BMP ordering rates with that one infrastructure change that was safe. There were no increases in ICU transfer rates, readmission rates, in-hospital morbidity and mortality. So we used that as a frame of reference and said, well, there was a 50% absolute reduction at Vanderbilt in this patient population. Let's take a more conservative goal and say we can reduce it by 25%. And our goal rate was having less than 70% of patients getting testing.
So it seems like another key, actually, lesson in successful implementation, which is that you defined what success looks like, and you made it achievable. And then, wait, did you end up actually achieving your goals?
Yes. So within a month.
If you did, this keys into I think a core sustainability challenge that actually hasn't come up on our previous webinars and podcasts, which is you know, you can win hearts and minds when people are watching the trend line move. But now that you're cycling off and there's like a new cadre of house staff that are working on this, you know, they're seeing a flat line, I assume. And the goal is to keep the line flat, not to have it go up, but that's much less motivating than watching it drop. Would you say that's the case?
That's absolutely true. And we've had refresher didactic sessions to target that issue, but you're absolutely right that initially when the trend line was going down, people get a lot more excited about that than a trend line staying at 70%. And we're staying at around 70%. And in a way, people will adjust to the expectation. So it seems that for the most part, those services now operate around a 70% goal. So they tend to be right around 65 to 75% of patients getting lab tests. But it has been difficult to keep individuals motivated about that specific aim. And I think a key precept in keeping people motivated about high value care in the context of a specific initiative is reminding them that this is a broader issue, and it's not only daily laboratory testing. This is just one metric that we're using to make everyone aware that we need to make sure that our history and physical skills are being adequately developed during training so that we don't overuse unnecessary testing as a whole in a broad sense, and understanding where extensive imaging tests like CT and MRI are truly indicated and when they're not indicated. So framing this individual small metric in the context of the broader issues, I think, is a way to keep people motivated. And while we aren't feeding back data on head CTs, although it's been discussed, and MRIs, we're not feeding that back now, making people aware that, hey, this is a way that you can see your data, but at the same time be participating in high-value care as a whole and being cognizant of that. Where I think we just didn't have enough voices talking about high-value care and discussing the issue of medical overuse. When I entered training in medical school, there was some initial movement in that direction, but keeping voices in leadership positions talking about the best care for patients is not necessarily the most.
Well, you feel like you may have now been coming up against maybe a critical mass of folks, and that actually goes to the question that I try to ask everybody that I have a chance to interview on this series, which is, what do you do about the people that don't care? You know, with really any campaign, you've got the people who were on your side to begin with. You've got the margin of people that maybe you can bring on your side and they're convincible, and you've got the margin that are really, really hard to convince. And how did you deal with that?
Yeah, I would say 5% of the residents we encountered were resistant and kept rates at 95 to 100%, and were difficult to engage in a dialogue. And as a trainee leadership initiative, this isn't going to be a solution when you're talking about faculty, but I would pull direct quotes from faculty that were leaders of the department and say, hey, this is what one of our leaders in our intensive care unit thinks about this work and how it's very important. This is what our program director thinks about it. So using leaders as a way to say, hey, this is really important. This isn't just one resident telling another resident to stop ordering tests. This is important in leadership sides. But you're right, you will always have a percentage, and I do think that it will only be 5 or 10% who will be completely resistant. I think that you have some degree of resistance from a cohort who sees a lot of high-value care and quality improvements initiatives as adding work for me. So it does take extra effort to say this patient doesn't need a lab tomorrow, this patient can go without a BMP or a CBC, as opposed to saying, well, let's just do it on everybody. We don't have time to think about who may have dynamic values or not. So I think that cohort can be persuaded by data success, but you're right, there will be a smaller cohort that will always have some degree of resistance.
That's fair enough. And maybe one final question as we wrap up. We talked a little bit about sustainability, but the other side of that is scalability, and how these kinds of efforts can be replicated in other settings. And I think you highlighted a bunch of things that I think are useful for other listeners and other folks who are interested in this, from making sure that you've defined what success looks like, you've got champions that you've identified, whether it's the program director, the ICU director that you mentioned, making sure that you've got data and you're feeding it back. One of the questions I actually have, though, given the way that this started, is that the complexity of overuse, I think, is that there are a lot of stakeholders, and the way that each stakeholder benefits doesn't necessarily overlap, right? Because you've got the patient in front of you, which is what we primarily care about. You've got the clinicians who are, actually for a lot of clinicians, it takes more work to be thoughtful about not getting the lab than to just do it on a daily basis, ironically. Mm-hmm. And you've got your institution, and actually that's the part that I want to ask about, because I think a lot of people are at institutions where they feel like people haven't quite jumped on the value train yet. And how would you describe the kind of initiative that you're doing in the context of your institution, the institution's business case, the transition to value-based healthcare more generally?
Yes, great question, and that has come up in the last month before I transitioned to another chief resident in internal medicine who's taking my place now. But we had a good dialogue with our quality department and institutional hospital administration about how we can integrate the Choosing Wisely Committee's activities with our institutional pillar priorities, especially around population health. So I think integrating your institution's population health goals, especially at academic medical centers, in terms of trying to track high value care, good quality at low cost, and making sure that that the work of a committee that trainees are participating on is congruent with institutional priorities is absolutely key to scalability. And I would definitely say we have not achieved high, very broad scalability. That is really what we're working on, is trying to maintain a dialogue between a committee that trainees participate on and hospital administration about institutional priorities for population health, and how can we integrate that with our high value care, our Choosing Wisely specific initiatives. Yeah.
Oh, great, Wade. Thank you so much for your time. Congratulations on everything that you've achieved at Vanderbilt with your team, and I know we'll be eager to see what the new team at Vanderbilt does based on the precedent that you've set, and we'll be eager to see what you do at Northwestern, at your new institution, and certainly lots of opportunities to bring this kind of thinking to your new field in oncology and hematology. So we'll be looking forward to hearing more from you.
Definitely. Thank you, Dr. Shah.
All right. Thanks so much.